Good evening, everyone. My name is Jim Bernetti. I'm an internist in Greenwich. I've been in Greenwich for over 25 years practicing. I was a resident here. We have our second lecture series tonight, which Dr. Park and Dr. Selkin are going to be speaking about gastroenterology. This is a lecture series which was made possible by a nice family in town, Icy and Scott France, who gave a donation to the hospital to enhance the hospital in some way. And we thought it would be best used as using a lecture series to sort of reach out to the town and speak to you about different topics that we think are very helpful. But in the meantime, we're mentoring 6 residents. There's 7 of us who are mentoring them. And they're residents at the hospital, and the Dr. Selkin has been in Greenwich for over 25 years, and fantastic GI person who has been a good friend as well. But all of us have reached out to the residents, and we're going to be working with them over the course of the next 6 months for this lecture series. So our hope is that we bring residents and we bring in a different group of new physicians to come into Greenwich and hopefully provide you all with some new blood and some new physicians, and we look forward to working with them. And thank you, Scott and Icy France, for this gift, and we hope you all like the series tonight.
Thank you, Dr. Bernetti. Thank you all for your patience. So my name is Dr. Park. I'm one of the residents here in internal medicine at Greenwich Hospital. I'm here with Dr. Selkin, one of the GI specialists here. So let's delve right in. So today we're going to talk about colon cancer, specifically about colon cancer screening and why early detection matters. And some of you may have had colonoscopies, some of you may have been suggested it but refused. But we'll talk today about why colonoscopies and screening is important. All right. So here are the main objectives for today. So we're going to discuss what is colorectal cancer. Why does early detection matter? How do we prevent it? Specifically, we're going to talk about colonoscopies and different non-invasive options. And we'll review the American College of Gastroenterology screening guidelines. So this is a group of gastroenterologists in the nation who, study different studies, and they come up with specific recommendations for screening. And after this presentation, we hope to answer some of these specific questions that you may have asked in the past. So what are some of the early warning signs of colon cancer? Who is at risk of colon cancer? When should you get screened? When should you start getting screened for colon cancer? Can colonoscopies help prevent colon cancer, which is different than screening? So to prevent means to get rid of something before it becomes cancer. So we'll discuss that in detail. Are there different options for colon cancer screening other than colonoscopies? And we'll answer specific questions about the specifics of colonoscopy. So what do you need to do to prepare for it? Will you be getting anesthesia? Should you stop any medications prior to colonoscopy? How long does it take? Do you need to take off work? And is it covered by insurance? And we'll talk about different age recommendations as well. All right, so what is colorectal cancer? So right here, we see the image of your colon and your rectum. So here where it says the ileum, so that's where your nutrition, your food, anything that you digest goes from your stomach to your small bowel to your ileum, then to your colon, and then to your rectum. So whenever cancer arises within this region, the colon or the rectum, we call that colorectal cancer. And this is more, this is a picture of a detailed, more detailed like polyps and cancers that we see in colorectal cancer. So initially, as you can see, here is, the cancer is benign initially when it starts forming. So it starts forming as these, what we call polyps, which is clumps of cells that start growing more rapidly compared to the adjacent neighboring cells. So they start growing, and it becomes an issue when the cells they start invading some of the lower areas of your colon and start invading your blood vessels, and then we have an issue of metastases invading through lymph nodes. So we don't want to get there, and that's why we want to catch the disease when it's benign before it becomes malignant. So we'll get back to that diagram a little bit later. So let's discuss some background about colorectal cancer. So how common is it? So it's the third most common type of cancer in both men and women. So for men, it'll be prostate cancer, lung cancer, and then colorectal cancer. For women, it'll be breast, lung, and then colorectal cancer. And at the same time, it is the third leading cause of deaths for men and women. For men, it'll be lung, prostate, colorectal. For women, it'll be lung, breast, and then colorectal. Unfortunately, we don't have good effective treatment for lung cancer, so those patients tend to not live as long as colorectal cancer patients and other cancer patients. And what are your risks of developing colorectal cancer? So the average risk for men is 1 out of 23. So out of 23 men, 1 man would develop colorectal cancer in their lifetime. And for women, it's 1 out of 25. And there are some other factors that increases your risk as well, and this includes age, family history of colorectal cancer, which are non-modifiable. So as you get older, unfortunately, you're at a higher risk of developing colorectal cancer, and if you have family history, unfortunately, you have a higher risk as well. Smoking, obesity, physical activity. So physical inactivity, I should say. So these are also associated with colorectal cancer, but these are modifiable. So these are things that you can work with in your day-to-day life to minimize your risk of developing colorectal cancer, as well as other cancers as well. Some of the less common factors that increases your risk include gallbladder removal, cancer of uterus or ovaries before the age of 50, history of inflammatory bowel disease like ulcerative colitis or Crohn's disease, or history of receiving radiation in the abdomen. So what are the symptoms of colorectal cancer? So we commonly know the symptoms of colorectal cancer as blood and stool, abdominal distension, pain, weight loss, changes in bowel habit like diarrhea, some rectal pain as well. But the important thing is that most early colorectal cancer do not produce any symptoms. So once you start developing symptoms, unfortunately, when we find out that you do have cancer, it's at a later stage where treatment may not be as effective at the time. So this is another reason why getting screened is very important routinely. Okay, so let's just summarize some of the points why early detection matters. So it's very common, so you should be screened regularly. Patients do not develop symptoms until later stages, which is very important. And the third point, which we'll go over in detail later, is that it can be prevented. So colonoscopy and doing a procedure called polypectomy, which is removal of polyps, which is the benign polyps that we discussed earlier. So during colonoscopy, these polyps can be removed, therefore preventing colorectal cancer. And with routine screening, your risk of developing colorectal cancer goes down by 90%, which is very, very significant. And again, if detected early, colorectal cancer can be treated and even cured. So it's very important that you all undergo routine screening. All right, so going back to this image, so the American College of Gastroenterology, the ACG, this is a quotation from their website: screening by colonoscopy and polyp removal prevents colorectal cancer before it can start. It's just to reiterate the main message of today's presentation. So colonoscopy is considered one-step method when it comes to screening for colorectal cancer. So you just do the colonoscopy and you're done. And the whole point, again, is to detect these masses when they're benign. And hopefully the gastroenterologist, like Dr. Selkin, can go inside your colon and remove them during colonoscopy. And these are some images of different forms and shapes of polyps. These are all benign. and these can be removed before they become cancerous. So some of the important facts about polyps is that they are benign, but they can turn into cancers, like we discussed. Not all polyps turn into cancers, but all cancers start as polyps. So it's best to remove all of them. They do not cause symptoms, and therefore routine colonoscopy is very important. So here's a picture of what you will undergo during colonoscopy, and if I can ask Dr. Selkin to maybe describe the process, the procedure, and what they would expect from it.
Sure. So just by show of hands, could you show me how many people have already been through a colonoscopy before? Okay, so yeah, many of you and some who have not. So but what we're going to try to do is demystify any concerns or anything that's that you're not aware of, and try to also encourage you, because most of you have had colonoscopies, encourage you to go out and talk to family and friends and people you casually come in contact with. March is Colon Cancer Awareness Month, so it kind of gives you the free authority to go up to people you know, or even strangers, and say, hey, it's Colon Cancer Awareness Month. Have you had a colonoscopy before? And you'll hear a little bit about the age that we like to start. But for the procedure, I think the big hero, we'd love to take the spotlight, but the big hero really is the anesthesiologist. Modern anesthesia, as you may be aware from being through procedures, and not just colonoscopies, but any kind of procedure that involves anesthesia, they really make a seemingly unpleasant procedure really a piece of cake. And from our standpoint, from the preparation and how we educate patients, a lot of patients have all sorts of concerns about what will it be like to go through the preparation. Will I be starving? Will I have to drink a gallon of salt water? And we do have every year newer and newer preparations, less and less volume, and we even now have tasteless tablets that one could consume with plenty of water or iced tea or lemonade, which will help cleanse the bowel. But the key here is a very clean colon is so important for us, because although these slides you saw prior to this one and this one, yeah, these polyps, they look like big monsters on a screen, but they're actually pretty small. And our scope will magnify the vision by about 16 times. So, and of course these are huge images you see here, but I'd say maybe the tip of your pinky or even smaller is what we're typically finding. And as Hun had just said a little while ago, not all polyps turn into cancers. We have to assume that any polyp we see could be the start of a cancer. So we'll remove any of them, but probably 5% or less of polyps would ever do that. So even though sometimes we refer to polyps as precancerous, I don't want to give patients the uneasy feeling that, oh my gosh, I would have developed cancer if they didn't find and take these out. We definitely want to find them. We definitely want to take them all out to go from a 5% chance to 0%. But for, again, a good colonoscopy, great preparation, which we always instruct our patients about as far as the diet. And you'd be surprised, even some of the things that we have in this room would be okay to consume in the day prior to colonoscopy. Juices and waters and lemonade and wonton soup without the wontons and chicken noodle soup without the chicken or noodles. So you're not starving. And then the preparation, as I mentioned, is becoming more streamlined. Clean, nice colon, wonderful anesthesia, and the procedure involves the passage of a tube about the width of your pinky finger, and it's flexible, and you go up and around to all the little recesses, because the colon is not just a straight tube, it's got some turns to it. And with the anesthesia provided, you really won't feel anything. It takes about 20 minutes to go through all of the recesses of the colon and get a good look around. And that is also inclusive of any time that it would take to take polyps out. And when patients awaken, aside from maybe passing a little bit of air, they're thrilled to have a little muffin or a little toast and some tea or some water or juice, and then they go home. A few days later, we will call patients, how are you doing? And also, if we found any polyps, what do they look like under the microscope? And as I mentioned, most polyps are indeed benign. So that's a little bit about what the pre and day of procedure involve. And we'll answer a few more questions as we go forward about the time that you need in the day prior to, the day of, and the day after.
Thank you. Okay, so that's the one-step method for screening for colorectal cancer. So there's another method if you prefer not to undergo anything invasive, which is referred to as a two-step method. So the first step involves stool-based test. So you will give us a sample of your stool, and it will undergo a test called FIT test, which will detect any blood in your stool. So if that becomes positive, you will likely undergo a colonoscopy to look for any source of that bleed. And as you can imagine, there's many causes to have blood in your stool outside of the colon and the rectum. So there will be high false positive rates for these stool studies. So we oftentimes recommend directly undergoing colonoscopies. There's also other stool-based studies like the Cologuard. You may have heard of this. It's a DNA test to look for any suspicious DNA that could come from cancer cells, which is also another stool test. And if that's positive, you will then undergo a colonoscopy as a second test. Now, if you don't want any of those tests for whatever the reason, maybe your insurance may not cover it. There's also other tests called flexible sigmoidoscopy, where the gastroenterologist will just go up until your sigmoid colon, which is just a portion of your entire colon, to look for any polyps. And if there are any polyps there, the gastroenterologist will undergo a full colonoscopy to look at the rest of your colon. There's also imaging tests as well, but we generally do not routinely do those here. From your experience.
Yeah, you might have heard of CAT scan colonoscopy or pill capsule colonoscopy or colonography. They're somewhat experimental, or at very most at a tertiary care. Maybe once or twice a year, a patient will come in and say, can we do a virtual colonoscopy? I heard them advertise it at some longevity center somewhere. But it's basically a similar preparation, meaning the same cleansing, and then a radiological test, meaning a CAT scan type test, with a little tube that inflates air into the colon, and no sedation is given. So I cannot even think of when I last recommended that. Usually it's a patient that found a center, and I say, well, any screening is better than no screening. So that's why the American College has recommended that these alternatives do exist. Again, a lot of researchers have put a lot of time and effort into these, but really the one-step colonoscopy test, because it's a 1 every 10 year recommendation, and because it is the most thorough, where we can actually find and do something at the same time, that would be the most common type of screening test that we do. But again, we do offer these other stool-based tests pretty commonly, actually. Cologuard is a test that's covered by insurance, and you collect a sample of stool, and there's a UPS label, and it's delivered to the lab, and they're fairly accurate. Sometimes because they have to not miss any possibility of missing a cancer, they actually over-report, meaning that the sensitivity of the test detects or amplifies the results to a point where they report some false positives, meaning the test was positive, but there really is no cancer. So we have a fair amount of patients, maybe even 10% of these tests are falsely positive on the Cologuard, and then the patient has to go definitely through a colonoscopy, because we don't know is it a true positive or a false positive, but we usually reassure them that it's a fair amount of false positives. Sometimes the positive doesn't necessarily mean a cancer either on one of those stool tests. It could be just a large polyp that has oozed a little bit of blood or shed some DNA. So again, as we always say, any screening is better than zero screening, and the most frightened or scaredy cat kind of person, we welcome them to at least start a dialogue so they know what all the options are.
So the best screening test is the one that gets done. So as Dr. Selkin said, please speak to your providers about your screening schedule, when you're next due for your colonoscopy, and so forth. So this is the ACG, the American College of Gastroenterology screening guidelines. So the age recommendation currently is 45 to 75 years old, which is a recent change from 50 years old to 75 years old. And that was changed in about 2018, I believe, a few years ago. So they're noticing that, you know, adults are developing colorectal cancer at an earlier age now, perhaps maybe associated with some of the modifiable risk factors that we discussed earlier, like smoking, drinking alcohol, and things like that. So that's the age recommendation. And the primary method that ACG recommends currently is the colonoscopy and the FIT test. So the colonoscopy is recommended every 10 years. And the FIT test, which is a stool test to look for blood, is recommended every 1 year.
Every what?
Every 1 year for the stool test. And every 10 years for the colonoscopy. And we will give you the instructions on your way out as well, so that you guys can have all of this information on your hand as well. And these are some of the recommendations for the alternative methods. So the Cologuard stool DNA test every 3 years, flexible sigmoidoscopy every 5 to 10, some imaging every 5 years. And just so you're aware, if there's a strong family history, your doctors may recommend you to undergo genetic testing as well.
So we talk about screening, we talk about like average risk. Patient doesn't have a brother who had polyps or a sister who had cancer, a person that didn't have a first-degree relative, a parent, a child, or a sibling with polyps or cancer. So whenever there's that type of family history, and it's amazing how often there is that kind of family history, we then go, to really heighten the timeline. And in fact, the every 10 year would be someone average risk, no one in their family, 10 years ago they had colonoscopy, okay, they're ready for it 10 years later. But if they had a polyp found during their initial colonoscopy, or if since their last colonoscopy their first degree relative developed polyps or cancers, then we really bring it down to about 5 years. So the 10 years, again, we want to get someone in at least once every 10 years, but the reality is, based on their personal history and the findings, we may increase the frequency to about every 5 years. It's very common. But again, with the anesthesia and all that, most people, when it's 4.5 years, they come into the office for their, to talk about their next one. They say, "Oh, doc, I know I'm so overdue." I say, "No, you're good. It's not quite 5 years yet." Because the lasting memory of their previous colonoscopy usually is pretty pleasant. So that was just a little way to kind of tweak some of those, screening guidelines.
So these are the list of questions that we reviewed earlier at the beginning of the presentation. So right now we're getting to the conclusion of the presentation. I think we should be able to answer all of these questions now without the answers that are shown. So some early warning signs of colon cancer, mostly none, as we discussed. So symptoms arise at the later stages of cancer. Who is at risk of colon cancer? We discussed different risk factors for average people, like age, family history, smoking, obesity, inflammatory bowel disease. When should I start getting screened? 45 years old. And when can you stop? 75 years old. But as Dr. Selkin said, a lot of these screening tests and health in general are personalized. So depending on your family history, depending on your prior medical history, different recommendations may be more appropriate for you. So it's more important that you discuss these things with your provider. Can colonoscopies help prevent cancer? Definite yes. We can get rid of polyps before they become cancers. And we discussed different options for cancer screening, like stool-based tests. We discussed bowel prep and laxatives for preparing for colonoscopy. Anesthesia, we discussed how excellent it is for you to stay very comfortable. One thing that we didn't really discuss is holding medications for your colonoscopy. Some of you may be on blood thinners for different indications, but if you're taking any blood thinners, we do recommend that you hold it for a few days. I believe it depends on the type of the blood thinner you're taking, but we're going to typically ask you to hold it before your procedure. How long does the procedure take? The colonoscopy itself takes about 30 minutes on average, I would say. But with the whole recovery process, getting registering and signing in, it'll take approximately 3 hours. How many days do you need to take off work? Probably just that day of colonoscopy. And is it covered by insurance? Yes, it is. And those are the questions. And again, I just like to leave with this message: the best screening test is the one that gets done. So please speak to your provider. And these are some of the slides that are presented by the American College of Gastroenterology. Oh, sorry. They call them excuses, but I like to call them reasons for avoiding colonoscopy. So even if you feel fine, even if you feel healthy, you may ask why get screened if you feel healthy. No one in your family has colon cancer, why get screened? You have no risk factors, only men get colon cancer. So a lot of these misconceptions can lead you away from getting screened for colon cancer, but as we discussed today, it is very important that we detect your colon cancer early if it's there, and that you undergo routine screening to prevent developing colon cancer.
Yeah. So I think it's worthwhile to also just take another peek at that last Q&A question, and we put the questions and answers here also for you to take home. And that's, at what age can we really stop doing this? And there's really no finite line in the sand as directed by any of our health associations. Some countries, there are very strict guidelines for the United Kingdom. 65 years of age, a lot of benefits are not going to be covered or paid for. In our country, if we feel that there is a need, if we have a patient that we feel has excessive or increased risk, we don't really draw that kind of line in the sand. And I think you'll appreciate that, aging gracefully, we're seeing very healthy people live very robust lives, well into their 90s and beyond. And I don't think a week goes by that I don't see a patient that is, well above 75 or well above 80 years of age who, feels, and I feel also in their internal medicine doctors feel that they're good candidates to continue. Because if say, an individual had a polyp at the age of 75, and we say, well, that's your last colonoscopy, they've had polyps before, they may even have a family history of polyps or cancers, and we just draw that line in the sand. Well, here they are at 80, 82, 84, living a very healthy, robust life, and a few weeks or months after their last colonoscopy, a little polyp was developing and had the intention to grow into something a little bit more aggressive. Well, wouldn't it be great for us to have had the opportunity to see that patient at 80 years of age and take that polyp out so it never had the chance? So it's a very individualized conversation to have, as we get above, mid-70s or so. And it involves, many factors, your personal preference, what your other healthcare providers have deemed as possible risks or not, no risks. The other thing I think we didn't really address it is, and some patients bring it up, and I think it's a conversation we always have, is, well, what are the risks? What are the risks of not doing anything? Well, obviously, not doing anything, we're just kind of rolling the dice. As you heard tonight, that the majority of patients, and I would definitely agree to this, the majority of patients in whom we find pretty high-grade lesions, meaning cancers, lesions, don't really have symptoms, or maybe even just a subtle symptom. So you really can't rely on, oh, my body feels great, I don't have anything wrong in there. So doing nothing is never a good thing. And I think the majority, I think everybody's here because they're interested in their own health, and they want to also spread, the knowledge amongst your family and friends. But also, what are the risks of the actual procedure? You're going through a bowel preparation, you're going through anesthesia, you're going through a procedure where the delicate colon is being manipulated with a scope, and air is being used. And we're just so delighted that, with the advancing of technologies, that the risks of untoward events has decreased substantially. So anesthesia risks, we have wonderful colleagues. Every patient that has a procedure, there is a certified anesthesia provider that gives you a medication called propofol, which is a very fast-acting sedative, and it really, under appropriate supervision, it really has a very low incidence of any untoward reaction, and it really doesn't create allergies, thankfully. The procedure itself certainly can create injury to the bowel, and luckily the overall statistics have been improving. Perhaps 1 in 10,000 times we encounter something such as a perforation where the colon is lacerated or cut by the scope, or where a biopsy or a polypectomy goes through all the layers of the colon. There was one slide there where a flat polyp was removed with a technique which we call a saline lift, where we actually create a little buffer. We raise the polyp up a little bit beyond the overall lining to really prevent the bowel to become injured. So we have lots of new techniques, and you can see the blue, okay, you can see the polyp above, and we injected kind of this blue solution which both lifts that polyp off the wall and creates a nice cushion for us to remove that polyp. And most polyps are not that broad and flat, luckily, and I know it looks like a big defect on that kind of that blue circle there, but that actually is cauterized and that heals very well. It's a rare complication to have bleeding after a procedure, but it's something that we always try to minimize with the use of cautery and clips and things like that. So we're just lucky to have wonderful colleagues and wonderful technology. And the other thing is, I'd say from a risk factor standpoint, is underlying cardiovascular disease, atrial fibrillation, things like that, arrhythmias, hypertension, and we always encourage a thorough conversation, between the gastro docs and patients, as well as if there's a cardiologist involved, internal medicine, obviously, who you see for the majority of your health care. So we really factor in all of these health concerns that patients may have, and try to minimize any underlying medical conditions to make things more complicated. So things like arrhythmias from electrolyte imbalance from taking preparations, we try to minimize by encouraging usage of some somewhat salty types of solutions like chicken soup and Gatorade and things that have electrolytes to minimize any potassium or magnesium changes. But these are all things that we always like to talk about beforehand. So as I said before, and by the show of hands, it looks like a lot of you have a lot of intimate knowledge and experience in all this. So if you'd like, at any time, just feel free to just let us know either about your personal experience, whether good or bad, whether you're concerned about having this again, anything that we might have brought up. Feel free to ask about. Sure.
If someone hasn't followed the preparation properly and there's not enough clarity, would you just postpone and reschedule, or do the best you can?
So there's the opportunity right when the patient is getting admitted. Our nurses will go through a pretty thorough checklist of how you're doing, what kind of experience you had, and in some cases, based on what we're hearing, what our conversation with the patient is, it's best to maybe either stay and get some enemas, or go home and take another dose of preparation. Or a lot of times what a patient feels is maybe inadequate actually was pretty good. And our scopes do have a water channel, like a water jet or a water pick, and we can actually irrigate and get underneath any residue that may still be there. So we always encourage a conversation even in the night. Like I'm on call tonight and I'm covering my practice. So as patients right now are going through their first or their second dose, we've encouraged them during our time that we set up the procedure, if you're having any issues with the preparation, or you feel it's not going well, or it's not kicking in fast enough, let us know, because we can intervene, sometimes in the wee hours of the morning, so that upon arrival we're in the best circumstance. But you're right, a good, clean result from the laxative is really what we're aiming for.
Thank you.
So you've talked about the large intestine. How about the 50 feet of small intestine? Is there any cancerous activity there?
So great question, and just as a general thumbnail sketch of the intestine, right? Starts in the mouth, ends in the anus, and I think of it as a 3-zone organ. So esophagus and stomach. So you swallow food, goes into the stomach churns all that food around, and then it releases it down that very, very long second part of the intestine called the small intestine, the small bowel. And then from there, as you saw from the slide, the ileum, which is the end of the small intestine, then delivers all the waste. The small intestine is the most important, in my opinion, part of the digestive process and anatomy. And we're thrilled that the small intestine rarely gives us a hard time. It's an unusual, infrequent place for cancerous growths. There are occasional patients that we encounter who come in with anemia or some bowel symptoms, and we do colonoscopies to try to find the problem, don't find anything, do an upper endoscopy, even a CAT scan, don't find a problem. But we have a capsule camera, which is about the size of a vitamin, which an individual comes in the office, and this is an outpatient type of procedure, no sedation needed because it's just like swallowing a jelly bean, and it takes photographs over about a 12-hour experience. It flashes photographs, and we can see in great detail the small intestine lining. So we'll use that technology for people who have chronic anemia in whom their colonoscopy and upper endoscopy don't show anything. And I'm proud to say I've been able to find a couple of small bowel tumors that way in patients who've been really through lots of testing. It's a fascinating technology. I love doing them. The yield is pretty low. We don't find a whole lot of things. Sometimes some obscure causes of bleeding, but I can think of one lady in particular, and she was elusive, just going back and forth, getting transfusions every couple of months, and we did that procedure. We found the tumor. Our surgical brethren, we try to locate it as best as we can based on how soon from leaving the stomach did it encounter this lesion, and lo and behold, he found it. And because, as you mentioned correctly, it's a very long water slide, the small bowel. Losing just a foot of it was really not a big problem for her, and she's cured from it. So very infrequent, very uncommon, definitely not the type of condition that calls for screening because it is so rare. But we do have technology to find those things.
So it wasn't a polyp, it was a lesion?
Yeah, it was called an adenocarcinoma, which means it was a cancerous growth. You know, it visually would have looked similar to one of the larger growths you would have seen in the colon. The colon is a much larger, think of like a softball, in caliber compared to say a golf ball, which is the small intestine. So when something grows in the lumen, as narrow as we'll say a small garden hose as opposed to a fire hose, a small lesion may obstruct, may cause more symptoms sooner, but usually they're more aggressive in the small intestine. So it's a mixed. We don't want to ever have to find those things, but usually a patient will have symptoms. Usually it's anemia, bleeding, and some bowel symptoms, but a pretty rare condition.
And you actually take out a section rather than just the...
Yeah, especially in a small bowel, if there's a large polyp or something that's bleeding. There are occasions where our scopes, are long enough through the mouth to be able to find something in the small intestine and snare it that way. But something that's larger and flatter usually requires an operation. Do any of you know people that... You go ahead.
You do endoscopics also, along with the...
So the term endoscopy means to put a kind of a camera tube into an orifice, right? So upper endoscopies through the mouth, and colonoscopies and sigmoidoscopies through the anorectal area. And we gastro doctors do the entire GI tract.
The whole line. Okay.
And then we have colleagues in tertiary care centers that have all sorts of neat technologies, scopes that are kind of a weighted a scope that kind of gets passed by the peristalsis, that's the natural motility of the gut, that go all the way down and then can be slowly withdrawn. Now that we have the capsule procedure, that's a lot easier on a patient, but there are ways with different types of enteroscopes to find unusual lesions. And sometimes we'll find something, or we'll identify a patient that needs, kind of a more esoteric type of scope. We're lucky with our affiliation with Yale New Haven. We've got some fantastic colleagues there, and we're on a short cell phone call away, and we get patients either, if they're an inpatient, transferred directly to them in a pinch, or sometimes an outpatient referral. And they're wonderful. They are absolutely wonderful colleagues to have. We're just so lucky to have that university backing. So anybody here know of any people in your world, whether it's a sibling, a child, a brother, sister, a parent, someone that works at Trader Joe's that you've had casual conversations with, and for some reason they just don't want to go through this?
It's a good idea to go to any of these different tests.
Oh, the other tests?
To find out if there is a polyps first. It then go to the colonoscopy, or... So
as you heard about this, what they call a two-step method.
Yeah.
That two-step method, the first step means, is in the stool, is there some indication that there may be something that's losing blood?
Must be done both of them.
So, right, so therefore it would be the two-step, meaning the stool would make us think, oh, there's something happening here, and then the colonoscopy will then identify.
Yeah, but you said one of these tests can show the polyps.
So, the only way to really to get right on top and see the polyps like you saw on the slides is through that scope, through the colonoscope. On rare occasions, sometimes one of our very astute radiologists, we've got wonderful radiologists here, will say, oh, a patient came in to have a scan looking for a kidney stone or something, and we see something that we don't like here in the colon. It's not too uncommon. Our brethren from the emergency room often say, oh, we have somebody here, and we did this scan, and something lit up, and we're a little concerned that there's a growth here. So yes, sometimes other types of tests may suggest that there's a problem, and then we can go right forward with a procedure that involves the colonoscope.
But with the history of polyps, it's probably better to go to colonoscopy.
Sure. Right, so that's really what we call, and that would be even an entire other lecture called surveillance. So screening means your first time coming in, or maybe 10 years after your last screening, this is average risk, everything is fine. Surveillance is, oh, hey doc, I had polyps back in 2019, or oh, I had to have a section of colon removed for a growth. So that would be, okay, come in every 3 years, 5 years. Usually that first surveillance.
Okay.
And that depends on how many polyps and basically the number of polyps.
Yeah. We have like an algorithm, right? Like how many polyps, what were they made of? Because many polyps are really, they look like little bumps or little growths, but under the microscope, the pathologist says, oh, that's just a little mucus, or that's really not much of anything. That's why our pathologist is a very important part of our team as well. We want to give them the fantastic credit they deserve, because anytime any cells are removed, whether you see a dermatologist or whether you go to a urologist or gastro, and we take a biopsy, take a sample, take a polyp, it goes on a special container to our wonderful pathology staff, and then they look at these cells under the microscope, and then we have an idea of how aggressive may these things be. But luckily, when a patient awakens from their procedure, and we found a polyp, even as like you'd seen on those slides, we can generally give you a pretty good sense of, oh, you don't have much to worry about. We're going to study this by the pathologist, but it's likely we'll see you in 5 years. And then sometimes we'll close the door, pull up a chair, and have to have a conversation about something that we're a bit more concerned about. But luckily, that's not a very common conversation.
You had mentioned medications to avoid, like blood thinners, anticoagulants. Now that everybody is on these GLP-1 agonists, Ozempic, Mounjaro, what's the rule on or how long you should stop those or avoid those before a colonoscopy?
Sure, and we started noticing this trend, as people were starting. You're familiar with the Mounjaro and Ozempic and these medicines that people take sometimes for diabetes and sometimes for weight loss and sometimes for both. Early on, before our anesthesiology brethren have published some guidelines on this, we would see that even in someone that drank an entire preparation, you'd imagine drinking lots and lots of liters of liquid to prepare for the colonoscopy, that sometimes we'd still see a lot of residue still in their bowel. And if they were at the same time as having a colonoscopy, sometimes we'll do an endoscopy as part of the same anesthesia or the same procedure. Patient has heartburn and they need a colonoscopy also, so we'll do an endoscopy. So usually we do the upper endoscopy first. So sometimes we were seeing, oh my gosh, this person has all sorts of material in their stomach even though they drank this preparation. How could that be? Well, it's because some of these newer medications, they work by, part of the way they work is by kind of limiting or slowing the motility of the intestine down. And when there's limited motility, the stomach can become more of a retention, it's essentially a bag, and it can retain food for many, many days. So some people that take those types of medications will complain of chronic nausea and a lot of heartburn and a lot of regurgitation and reflux. Again, for the appropriate patient, they're great, and we absolutely encourage their use. But in preparation for a colonoscopy, we do ask that they hold it for 1 full week. And some of them have a few nuances to them, some of the oral medicines versus the injectable ones. But for the most part, the American Association of Anesthesiology has declared that because the risk of something called aspiration increases when there's retention of material in one's stomach, that means that when we go to sleep, our barriers or our defenses kind of decrease. So if you lay down and there's a lot of food in your stomach and you go to sleep, and certainly if we have an anesthesiologist put you to sleep, you don't have that protective cough as vibrant and vigorous as it would ordinarily be if you were awake, and we don't want a patient to aspirate. That's why, you might know that for an anesthesiologist, one of the first things they'll ask you is, when did you last eat anything? And that's a very important thing, to be on an empty stomach. So those types of medicines are generally held for a week.
A relative recently aspirated, and we talked about it. And what I found was most people don't know what aspirate means.
Yeah, right. So again, it's the moving of material from one's stomach into the lungs. So it's kind of a regurgitation and inhalation. And it's more common in people who have had, certainly put to sleep, anesthesia, even at nighttime, just any average individual. And we talk about, again, our talk today is about screening colonoscopies, but for gastrodocs, we deal with a lot of heartburn, right, and a lot of patients who have upper digestive issues. And very commonly, patients will say, "Doc, in the middle of the night, I sometimes wake up and I'm coughing and I'm gagging, or sometimes, I still taste dinner even the next morning." And the first thing I'll ask them is, "Well, what time do you eat dinner, and what do you do between dinner and bedtime?" And it's amazing, and maybe some of you are guilty of it too, but that wonderful tray back there with the brownies and the cookies, I mean, that's I could eat those things late into the night, but I know, and I've learned from personal experience, if I eat any of that stuff, 6, 7, 8, 9 o'clock at night, I will have a horrible night because of aspiration. Now, aspiration could be flagrant, meaning, oh my God, you can end up in the emergency room coughing, low oxygen, pneumonia, because that material came up. We know that fatty foods and spicy foods and alcohol really increase the likelihood of material coming up. And when you lay down on a full tummy and you don't have gravity anymore to help you, so it's common to aspirate. But in this case, Wegovy and Mounjaro and Ozempic will further complicate things by telling the stomach, well, we don't want you to empty, any kinds of foods for a long period of time, so the stomach hangs on to foods. So any food in the stomach that is subject to gravity or the lack of gravity when you lay down, or the weight of your body squeezing it against the mattress, that water sac called the stomach will very often lead to reflux, and reflux can lead to regurgitation and aspiration, and none of us want that. And even subtle aspiration is that cough and congestion and throat clearing and hoarseness. A lot of the ear, nose, throat doctors send patients back to us who say, you don't have a problem with your sinuses, you have a problem because you lay down on a full tummy. So that's an important part of the education for upper digestive wellness, but this medication, or these medication class, although have fantastic benefits, sometimes, especially in the pre-colonoscopy patient, we really have to discourage its use. And in fact, anesthesiologists, it's one of the questions they will ask, are you on these GLP? That's what the class is called, the GLP type medicine, Ozempic type medicine. How long have you been off of it? And the worst thing, we're so sorry to say to a patient, you use the injection this week, we can't do the procedure. Once in a while we'll have that patient and they're very motivated that, doc, I carved out all this time, I need to have this screening colonoscopy, I took my prep, I'm clean and clear, and I know I took the Ozempic 6 days ago and the anesthesiologist says it's got to be 7 days. So we can offer a no sedation colonoscopy. I know it doesn't sound like a lot of fun, but actually patients that we've done this on for a variety of reasons, whether they want to drive themselves home or whether they're just super type A, or whether they took a shot of one of these GLP medicines within the week. Very cautiously and carefully, we insufflate a little air and we kind of navigate around. The colon, as you might have seen from the picture, think of it like an accordion almost, right? So if you see an accordion totally compressed, it's really not that long of a structure. But as you separate and as these folds, the colon is like an accordion, lots of little folds. So we don't really need to put 6-7 feet of scope into someone if that's really how long the colon is. We look at sections, and we use, you see those little kind of transverse, we call them haustra, or think of them as little sacs or folds, and they're very compressible like an accordion. So we can look at a segment of colon by using some air, and then we'll take the air out, and then we can sleeve, right? Like if we have the sleeve, we could sleeve the colon onto the scope and look at another section and another section. So sometimes we can get all the way from the rectum to the appendix with a very short amount of scope if we use this kind of sleeving technique. So just, I think what I'm trying to relate to you is that, oh my God, you're going to use a scope that long for an organ of that length. Well, the truth is, it's very elastic, and again, it's kind of in a series of folds. So even in someone without sedation, they generally can do it pretty well.
So I know some people are very much into these total body MRIs, right? They're going and they're paying whatever out of pocket. Can the MRIs detect any kind of lesions in the colon?
Absolutely, they absolutely can. We don't have, I don't believe we have the algorithms here. I think for maybe a brief period of time we were toying with it. I know there's some centers in Manhattan that do some of these virtual colonoscopies. The problem is that small lesions, flat lesions, I think the rule of thumb used to be anything smaller than the tip of one's thumb, they may not see very well. And then the reverse of that would be something like stool or maybe an inverted diverticulum. A diverticulum is a pouch, an outpouch of the colon, and sometimes the way that they can involute or kind of flip inside themselves, they can sometimes look like a polyp on an imaging type of scan. We welcome the advancement of technology, and when the whole concept of virtual colonoscopies were starting to come out late 90s, early 2000s, and there were, again, it's more of a computer algorithm that the radiologists were using. Again, same type of preparation, some contrast, meaning some air needed to be insufflated into the colon. But we welcomed it as gastroenterologists because we knew that they're going to find a lot of lesions, and we're all going to be, partners in figuring out what is happening there. So I'm sure that, and I'm sure there's plenty of data in their literature as to the advancement of that. And as we said, any test that anybody could go through. In the old days, it was something called a barium enema, where again, barium is a liquid. We call it a contrast liquid. So you fill the colon with a contrast, and anything that's kind of pushing in from the bowel wall would kind of be outlined. So instead of seeing kind of a white smooth line, you see a white smooth line with kind of a knob in the middle of it, and that contrast would indicate, well, there's something there. Well, was it stool? Was it an inverted diverticulum, kind of an outy diverticulum, or was it really a lesion of any sort? So yeah, I think there's definitely, and I'm sure there will always be, advancement. We hear about all sorts of neat technologies that, total body scans that'll find things, and we'll all benefit from these things for sure. But when it comes to finding something or the suspicion of something being found, we're always going to have to do something mechanically to kind of remove these lesions, or certainly investigate what they may be.
So bottom line, there's no substitute for direct visualization.
Yeah, that's that's why they call it the gold standard. That not only could it be a diagnostic test, but also a therapeutic test. And every so often a patient will come in and say, "Oh, doc, well, if you find a polyp, then do I have to come back right away?" Well, no, we take care of it right then and there. We would take care of it right then and there. The anticoagulation story, again, is individualized: aspirin, Plavix, Coumadin, Eliquis, and sometimes we'll actually still do a procedure on somebody on these medications in certain circumstances. Sometimes, very often, there'll be the dialogue with all the healthcare providers you've seen as to who could come off of what. But always have that conversation. Don't just stop any of these things.
Are there any other questions?
Next month's topic?
What's next month's topic?
ICU care and advanced directives, and there's flyers over here.
Great.
Thank you.
So we do have monthly lectures scheduled up until June, so please join us whenever you can. It'll be related to any common health topics related to you guys, so please join us.
Yeah.
Thank you for your time.
Yeah, thank you. And you'll start to see in the various media, every major preventable disease and disease that we could screen for, prostate cancer, breast cancer, colon cancer, has its own month, and March is Colon Cancer Awareness Month. So it's just a way that you could open up the dialogue. If you know somebody that you really think, wow, this person's 55, they never had it, I wonder why. This is like your free pass to say, hey, it's Colon Cancer Awareness Month. That's the only reason I'm bringing it up, and you may save some lives. So go out there and spread the word. Great, thanks, and definitely pick up a little literature on the table there, because especially the question and answer, you could be a pretty good source of information just by looking at those.
And we have some free goodies as well.
Yeah, take some good.
Yeah.
Thank you.
Yeah, some probiotics and whatnot. Very good. Hey, thanks.